Hello everyone, and welcome back. This is a neurology follow-up video, which I forgot to include surgery, neurosurgery, and OB-GYN surgery, which is extremely small section for the original neurology video. I also do have some pediatric neurology. It's a lot to cover for pediatrics. So I'll see how long this video is, and if it's too long, then I'll just do another separate one for pediatrics. If not, I'll just throw in pediatrics on this, but I'm pretty sure it's just going to be in one long audio lecture here. But thanks again, everyone, for the kind support and for the kind words. I really am happy that this is getting through to some of you guys, and I really appreciate that all the comments you guys given us. It's a lot of positivity there, and right back at you. I really hope this is helpful in any way, shape, or form for your examinations and rotations or whatnot. It's also good for me. I get to use it as a continuous education kind of review, and I'm really happy to be able to put this out for you guys. I wish I had something like this for myself, so why not? All right, so anyway, enough of that. Let's go and dive into neurosurgery. So in neurosurgery, we're going to go into upper limb, lower limb, then some superficial nerves, facial nerves, stuff like that. It's a pretty quick rundown. So let's start off with upper limb, and in the upper limb, we're going to see the rotator cuff, the anterior shoulder dislocation, rupture of the long head of the biceps, as well as long thoracic nerve injury and brachial plexus injury. So let's start off with the rotator cuff tears. So the anatomy of the rotator cuff, it's formed by a group of tendons, and this group is the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So those muscles all form the rotator cuff, or tendons. And I remember the mnemonic SITS helps me. So SITS stands for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. So in particular, the supraspinatus is most commonly the one injured due to repeated bouts of ischemia near the insertion of the humerus, induced by a type of compression between the humerus and the acromion. And the common causes here would be like if you fall on an outstretched hand. So that's going to be the most common fall. It's somebody who's falling on an outstretched hand. You'll have clinical findings would be severe shoulder pain and edema, as well as an inability to abduct past 90 degrees. And the way you test this is with the drop arm test. That's a maneuver that you can help diagnose a rotator cuff tear. So the patient's arm is going to be abducted passively to greater than 90 degrees. And the patient is then asked to lower the arm slowly. When you have a complete rotator cuff tear, the patient won't be able to lower the arm very smoothly, and it'll just suddenly drop around the 90 degree position. So if you have that, that is an indication of a rotator cuff tear. Pretty straightforward, easy question. It will be on the exam. Probably. I had it on my exam, and they loved that on Uworld. For anterior shoulder dislocations, here, the cause here is a forceful abduction and an external rotation of the arm. So this is going to cause an anterior dislocation of the humeral head from the glenoid fossa. And that's going to then cause the anterior capsule of the glomerular joint to be torn. You'll have a resistance with internal rotation of the arm, and supports the weight of the arm on the other hand. So that's how it'll show up, with resistance of internal rotation of the arm. On physical exam, the area of the acromion, the prominence of the acromion with abnormal subacromial space, where the humeral head normally resides, and there's also going to be fullness of the anterior shoulder noted on palpation. So you're going to see the anterior shoulder is going to be very full. When do you warrant neurological examination of the axillary nerve? And that's right there, that's a risk of injury due to an anterior inferior dislocation, and that's going to then cause paralysis of the deltoid and the teres minor with a loss of sensation over the upper lateral arm, and it can also damage the axillary artery. So next up, so that was anterior shoulder dislocation, very common. I didn't write here posterior. Posterior is going to be less common. These are going to be more for like electrical shocks, something which require extreme amount of tension and force. So if you see like an electrical shock problem, you got hit by lightning or something, that would then cause posterior, but anterior is the most common. So now moving along, we have rupture of the long head of the biceps. And here, this is going to produce a positive Popeye sign. So Popeye the Sailor Man, where the bicep muscle belly becomes prominent in the mid-upper arm. And there's weakness with supination. That's very prominent. And the forearm flexion but the forearm flexion is typically going to be preserved. So that's your Popeye sign. It's a rupture of the long head of the biceps. So right in the middle of your arm, you're just going to see a huge, your forearm is going to show a huge bulge there. All right, or not your forearm, sorry, your humerus. So long thoracic nerve injury is next, and that's during an axillary lymphadenopathy. The serratus anterior palsy is going to cause a winged scapula. So, I mean, you have to see the picture, but it's going to show a flattening of that posterior muscle there. So the scapula is going to be winged in that case, and that would be a long thoracic nerve injury due to a serratus anterior palsy. And then we have brachial plexus injury, and that's the lower trunk of the brachial plexus that's going to originate from C8 to the T1 cervical roots. It's going to result from a sudden upward pulling on the arm, and that's going to lead to a Klumpke's palsy. Primarily, it's going to affect the muscles innervated by the ulnar nerve, which is going to supply most of the intrinsic muscles of the hand, causing a weakness and atrophy of the hypothenar and the interosseous muscles, as well as claw hand deformity can result. So just remember that. That's a lower trunk of the brachial plexus. C8 to T1 nerve roots. They do ask that. Okay, now we're going to go and venture off into the lower limb, the femoral nerve. Now its function is for leg flexion at the hip, as well as leg extension at the knee. So when you're looking at it anatomically, it's going to be like the anterior portion of the thigh, anterior distal portion of the thigh, the knee, and the medial aspect of your leg, right? So that's the innervation there. And the motor and sensory portions of the femoral nerve, the motor is going to innervate the muscles of the anterior compartment of the thigh, like we just said, the quadriceps femoris, and the pectinus sartorius. So just remember the anterior compartment of the thigh. Sensory is going to affect the anterior thigh as well as the medial leg via the saphenous branch. All right, so that's the femoral nerve. They do like to kind of describe to you some kind of dermatomal pattern of sensory loss or something like that. And if they start saying anterior thigh, medial leg, and they're looking for nerves, and that's going to be the femoral nerve. Now the tibial nerve, motor innervation is that it's going to innervate muscles of the posterior compartment of the thigh. And the posterior compartment of the leg, as well as the plantar muscles of the foot. So everything in the back, right? Flexion of the knee and digits and plantar flexion of foot. So all those posterior aspects, as well as plantar flexion, those are all going to be associated with the tibial nerve. And sensory on the leg is going to be everywhere on the leg except for the medial portion, because that's the femoral. And the sensory is also going to be on the plantar part of the foot. All right, so that's tibial nerve, posterior, everything anterior, think femoral. And medial is going to be femoral. Next up on the lower limb is your obturator nerve. And this is going to function as adduction of the thigh. So because of it, since it's adduction, you want to adduct, remove, right? Or adduct of the thigh is going to specifically have a loss with sensory loss with neuropathy on the medial aspect of the thigh. So motor is going to be the medial compartment of the thigh, like we said. So like the gracilis, the adductor longus, the adductor brevis, the anterior portion of the adductor magnus. So anything with adduction in it, think of obturator nerve. And then sensory is going to be the medial thigh. So like recap it really quick. Anterior thigh is going to be femoral nerve. Anterior thigh, medial leg, femoral nerve. Anything posterior on the leg, think of the tibial nerve. And if it's a medial thigh, then it's obturator. So medial thigh is obturator. Medial leg, or like the distal leg, is going to be femoral. So now the next one is your common peroneal or fibular nerve, and this is going to give rise, sorry about that, this is going to give rise to the superficial and the deep peroneal nerves. Motor innervation is that these two are going to supply, these two nerves, the peroneal and the fibular nerve, are going to supply the muscles of the anterior and the lateral leg. And the sensory portion is going to be anterior lateral leg, as well as the dorsum of the foot. They're going to, since the anterior lateral leg is kind of, can happen with femoral nerve or tibial nerve, they might just ask you dorsum of the foot. That's going to be more common. So if they say dorsum of the foot, this is common peroneal or fibular nerve. Remember, plantar of the foot is tibial nerve. All right, then you have your superficial peroneal nerve. And the superficial peroneal nerve, its motor function is going to be foot eversion. So because of that, that's going to affect also the dorsum of the foot, as well as the lateral aspect of the distal leg. Then you have your deep peroneal nerve, and this is in charge of foot dorsiflexion as well as toe extension. The deep peroneal nerve is located in between the first and second toes. And that's about it. Next up, we have facial nerve, which is an extracranial part that passes through the substance of the parotid gland, and it gives motor innervation to muscles of facial expression. For the facial nerve, the parotid for a parotid gland tumor, this requires deep lobe parotidectomy. Sorry guys, I sound like Elmer Fudd here. Parotid gland tumors require deep lobe parotoidectomy, or if it involves the facial nerve, then excise the nerve too, and that can cause a unilateral facial drop. Okay, so facial nerve, parotid gland tumor. So if they say innervation of the parotid gland, think facial nerve. And honestly, guys, that's all there is for neurosurgery. Apparently, it almost feels like it's musculoskeletal in a way, but no. And then the very short section on OB-GYN neurology is going to be divided into just two syndromes or diseases, is the fetal hydantoin syndrome and congenital syphilis. So for fetal hydantoin syndrome, this is due to exposure to many kinds of anticonvulsant medications during fetal development. Most commonly, its associated medications for fetal hydantoin syndrome is phenytoin and carbamazepine. Clinical findings would be mid-facial hypoplasia. There can also be microcephaly, cleft lip and palate, rib anomalies, digital hypoplasia, as well as nail hypoplasia. There can be hirsutism and developmental delay. In pregnant women on phenytoin during their last trimester, they often receive prophylactic vitamin K to prevent neonatal bleeding, because phenytoin can increase the rate of fetal vitamin K degradation. So they love to ask that vitamin K gets degraded very quickly with phenytoin use. So you kind of need to give them prophylactic vitamin K. All right, so fetal hydantoin syndrome, just remember phenytoin. So they both have Owen in the name, right? Maybe that helps. All right, congenital syphilis, finally, is signs present following birth. For congenital syphilis, you're going to have the snuffles, so the rhinitis, hepatosplenomegaly, and skin lesions. And later on, there's going to be interstitial keratitis. They're going to have the Hutchinson teeth, the saddle nose deformity, saber shins, so they kind of like, they have like a bowing on the shins, and deafness, as well as CNS involvement. So I think that one's kind of clear cut for congenital syphilis. And fetal hydantoin syndrome with phenytoin or carbamazepine use. And that's it, guys. That's it for neurology, OB-GYN, and for neurology surgery. And we are at about 16 minutes, going on 17 minutes, so I might as well just start off pediatrics. It's a couple of pages long. Maybe I can get it down within an hour. So let's see what we can do. All right. So for neurology in pediatrics, so first off is going to be developmental milestones during toddlerhood. So we're going to break down between the ages and what you'll find during those milestones, right? So at 12 months, gross motor findings are going to be that they stand very well. They can walk their first steps independently, and they can throw a ball. So by a year, they're going to be able to do those things. For fine motor at 12 months, they'll be able to have a 2-finger pincer grasp. They're going to be, for language, they're going to be able to say their first words other than mama and dada. And, not dada, dada, dada. They say data, just be worried. And then social cognitive, they're going to have some type of separation anxiety, and they are also going to follow one-step commands and gestures. So those are the developmental milestones for 12 months. At 18 months, their gross motor findings are they're going to be able to run, they're going to be able to kick a ball. For fine motor findings, you'll see that they'll be able to build a tower of blocks, so 2 to 4 cubes, and they can remove their own clothing. Language, they can already increase their language to 10 to 25 word vocabulary, and they can identify more than one body part. For social and cognitive, they're going to be able to understand the word mine, like mine, the little seagulls in Finding Nemo. And they're going to begin to pretend to play. So they begin pretend play at 18 months. Okay, so then we jumped forward all the way to 2 years of age, and at that point they're going to be able to walk up or down the stairs with both feet on each step, and they're going to also be able to jump. They're going to build, for fine motor, they're going to be able to build a 6-cube tower, and they're also going to be able to copy a line, and they're going to be able to turn pages on a book. Language, they're going to have more than 50 word vocabulary as well as 2-word phrases. And for social cognitive milestones, they're going to have they're going to be able to follow 2-step commands. They're going to have parallel play, which means that they can run, they can throw a ball overhand, they can kick a ball, even though they can kick a ball at 18 months. And they can also begin toilet training. So all those are at 2 years. Now, move along at 3 years. Again, they're going to be able to walk up or down the stairs with alternating feet this time. At 2 years, remember, it was walking up and down the stairs only 1 foot at a time, or with both feet. But at 3 years, they're going to be able to alternate. So 1 step, right foot, next step, left foot, like that. And they're going to be able to ride a tricycle. So tricycle, 3 wheels, 3 years old. That's pretty easy to remember. They're also going to be able to copy a circle and use utensils. Their language is going to be already advanced to using 3-word sentences, and their speech is about 75% intelligible. For social and cognitive milestones, they're going to know their own age, they're going to know their own gender, and they're going to have imaginative play. So that all happens at 3 years of age. At 4 years old, they're going to be able to balance and hop on 1 foot. They're also going to be able to copy a square. So a square has 4 corners. So 4 corners, 4 years old. So that's another easy one. They're also going to identify colors, and their speech at 4 years old is finally 100% intelligible. And for social cognitive milestones, they're going to be able to have cooperative play between other children. At 5 years old, gross motor milestones are going to be able to skip. They're going to be able to walk backwards. For fine motor, they're going to be able to copy a triangle, tie their own shoelaces, and they can take a bath and get dressed on their own. And they can also print letters. For language, they can count to 10, and they can have 5-word sentences. So 5-word sentences, 5 years of age, easy to remember. And for social cognitive milestones, they're already going to have friends by 5 years old, and they're going to complete their toilet training by 5 years old. And what you should know about audiological testing, this should be performed in all children with language delay, and that's used to assess for any type of underlying hearing loss. All right, so moving on, we have complications of prematurity. Complications would be like respiratory distress syndrome, patent ductus arteriosus, bronchopulmonary dysplasia. There can be intraventricular hemorrhages, necrotizing enterocolitis, as well as retinopathy of prematurity. So the first one, intraventricular hemorrhages, it's a common complication in neonates born prematurely. Less than 30 weeks gestation is going to be pretty premature. Or if they're less than 3.3 pounds or less than 1,500 grams, they're going to have higher risk of intraventricular hemorrhaging. Pathophysiology is going to be a capillary fragility of subepidermal germinal matrix, and as well as immature autoregulation of the cerebral blood flow. Screening for intraventricular hemorrhage would be serial head ultrasounds. That's necessary because 25 to 50% of cases are going to be asymptomatic. So you need to do a serial head ultrasound. And the way they present is going to be with like lethargy, hypotonia, a high-pitched cry. So not just gosh, I think I'm heroin there. Not just heroin use. It's also seen in intraventricular hemorrhage, the high-pitched cry. Also rapidly increasing head circumference and bulging fontanelles. And these can be seen with severe hemorrhages. All right, and then complications of an ventricular hemorrhage would be communicating non-obstructed hydrocephalus, seen in 1/3 of cases, as well as accumulating of blood, because the accumulation of blood is going to irritate the arachnoid villi. And that's going to impair its ability to absorb the CSF, thus causing the obstructive hydrocephalus, a communicating hydrocephalus. There's the greatest risk of death in high-grade bleeds. Those who survive are often going to suffer from a significant neurodevelopmental disability like a cerebral palsy. And the way you prevent this is you want to prevent preterm labor, as well as antenatal administrations of steroids, and only interventions that can decrease the risk of intraventricular hemorrhage would be those two, to prevent the actual preterm labor and to give them antenatal steroids. Pretty sad, but those are it. For Lesch-Nyhan syndrome, this is our next topic. This is an X-linked recessive disorder. It affects only the males. The deficiency is of a hypoxanthine guanine phosphoribosyl transferase deficiency, so the HGPRT deficiency. And that's involved in purine metabolism. So, like we all know from step 1, uric acid is going to start accumulate in the peripheral tissues, which is that increasing uric acid is going to cause a gouty arthritis, as well as tophus and obstructive nephropathy. And if you start to suspect this syndrome, if you see a little boy with gout, right? Because normally gout appears after they're an old man, after they're 50. And it presents at 6 months with hypotonia and persistent vomiting. And the clinical picture is going to worsen thereafter with progressive mental retardation, as well as chorioathetosis and spasticity. There's also going to be a dysarthric speech, dystonia, and compulsive self-injury, especially biting of the upper extremities. So if you just see in the vignette somebody who, well, it's obvious, somebody who starts, a little kid that starts biting themselves, trying to feel some kind of pain. That's why they bite. They can't feel anything. They're just full of uric acid. So they're biting themselves, think Lesch-Nyhan syndrome. And the treatment here is going to be to decrease that uric acid level with allopurinol. And patients should be advised to take adequate amounts of fluid as well. Next up, we have phenylketonuria. And the pathophysiology here is that it's an autosomal recessive mutation in the phenylalanine hydroxylase enzyme. And it's a failure to convert phenylalanine into tyrosine, which is going to result in a hyperphenylalanemia as well as neurological injury. Clinical features of phenylketonuria would be severe intellectual disability. They can have seizures, and the big one here is the musty body odor. They did ask this on my exam, and they straight up said musty body odor. And hypopigmentation involving the skin, the hair, the eyes, and the brain nuclei. They also like to say just like fair hair, fair skin, or they'll present you with a kid, and they'll put in the effort of typing in that the kid has like blondish hair or light hair. Why else would they type that in, right? So the diagnosis is a newborn screening. That's a tandem mass spectrometry and a quantitative amino acid analysis, which is going to show increased levels of phenylalanine. But that's if PKU is suspected later on in life, then that test is done, the quantitative amino acid analysis. Other than that, newborn screening. And treatment would be dietary restriction of phenylalanine. That's about all you can do. The tandem mass spectrometry is done on dried blood spots to detect metabolic products of phenylalanine, and that's the most cost-effective screening is the tandem mass spectrometry. Phenylalanine itself, remember, that's an essential amino acid, and small amounts of that is needed for growth and development. So a diet that's low in phenylalanine is given. So cereals, starches, fruits, vegetables, and phenylalanine-free milk formulas are going to be recommended. High-protein foods are going to be avoided. The prognosis for phenylketonuria is going to be based on early diagnosis and treatment. And most patients have normal mental development and normal lifespan because as much as it sucks that all you can do is restrict phenylalanine, but just by doing that, they're able to continue on and have somewhat of a normal life. Next up, you have homocystinuria and Marfan syndrome. And we're going to speak now about the differential diagnosis of a marfanoid body habitus. So because both of these are very similar, so and they love to ask about these two. So in Marfan syndrome and in homocystinuria, they're going to have almost the same they're going to have overlapping features and distinguishing features. Now, the ones that are completely the same, that aren't going to distinguish one from the other, is they're both going to have pectus deformity. They're both going to be tall. They're both going to have increased arm ratio, arm to lower arm ratio. The upper arms are going to be longer. They're also both going to have arachnodactyly, so their fingers are going to look like really long spider fingers. They're both going to have joint hyperlaxity. They're both going to have skin hyperelasticity, and they're both going to have scoliosis. So if you have that picture in your head, which they most definitely will ask, it's not going to tell you much other than it's either Marfan or homocystinuria. Now, how can you distinguish them is that in Marfan syndrome, they have an upward lens dislocation. They also have an aortic root dilation. Their intelligence is normal, and it's an autosomal dominant mutation. So those are the distinguishing features. And in versus homocystinuria, these have a downward lens dislocation. They also have intellectual disability. They have thrombosis. It's autosomal recessive, and it's also associated with fair complexion, as well as megaloblastic anemia. So remember, the fair complexion can also be PKU, right? We just said that PKU has also fair complexion, but in homocystinuria would be a tall child with fair complexion. So the ones that I always am quick to look for on the question is going to be where their lens is located. Is it going up or down? So if they're Marfans, they're looking up to Mars, and if it's homocystinuria, they're looking down at their urine. That's how I remember. So yeah, so the lens dislocation. If they don't give you that, then check to see if how is their intellectual profile. They're normal intellect, it's Marfans. And if they have, if they're not, they have intellectual disability, then that's homocystinuria. So the way I remember that is that for some reason or another, I keep thinking Michael Phelps, the Olympic swimmer, he just looks to me like he has Marfan syndrome, or Abraham Lincoln, he looks like he had Marfan syndrome. And they both seem very intelligent people, so that's why I'm thinking Marfan syndrome would be more for the normal intellect. Homocystinuria would have the intellectual disability. Okay, moving on. So let's just go over homocystinuria really quickly. I have another thing here on homocystinuria. It's an error in the methionine metabolism, and that's due to a deficiency of cystathionine synthase deficiency. There's thromboembolic events that can occur at any age due to pathological changes in the vessel walls, as well as an increase in adhesiveness of the platelets. Most commonly, it's going to involve the cerebral vessels. And the diagnosis here is going to be an increase in homocysteine and methionine levels. And the treatment is with vitamin B6, folate, and vitamin B12. So if you give them that, that's going to decrease homocysteine levels. And you also want to administer antiplatelets or anticoagulation to prevent a stroke, like coronary heart disease and venous thromboembolic disease. All right, moving on, we have disorders of fructose metabolism. Sorry about the audio. In the past couple of minutes, I was outside and recording and it started raining. But anyway, disorders of fructose metabolism is aldolase B deficiency, and that's the introduction of fruits and vegetables in the diet. That's going to lead to a fructose 1-phosphate accumulation. And it presents with vomiting, poor feeding, as well as lethargy. And then you have seizures and encephalopathy can follow if the fructose isn't discontinued. So if they keep having fructose, they can present with vomiting and poor feeding, as well as lethargy. All right, next is disorders of galactose metabolism. So fructose metabolism problems is aldolase B. Whereas disorders of galactose metabolism is a little bit more specific. You have galactokinase deficiency and then galactose 1-phosphate uridyl transferase deficiency. So for galactokinase deficiency, they're going to show up with bilateral cataracts only. There's no other symptoms there. Versus galactose 1-phosphate uridyl transferase deficiency, this is going to present in newborns or in infants with failure to thrive and poor weight gain. They're going to have bilateral cataracts as well, vomiting, jaundice, hepatosplenomegaly. They can have hepatic cirrhosis and hypoglycemia. Also, they can get elevated levels of blood galactose, obviously, convulsions, amino aciduria, mental retardation, and then there's a high risk of E. coli in neonatal sepsis. Early diagnosis and intervention is important for the better survival outcome, right? And it's also used to prevent liver cirrhosis as well as mental retardation. The treatment is early elimination of galactose from the diet. That can reverse growth failure, and it could reverse any other organ complications like renal failure and liver dysfunction. So eliminate galactose from the diet. So remember here, the galactose problems, you have galactokinase and you have the galactose 1-phosphate uridyl transferase. So the one with the longer name is the one that has the more problems. They do like to ask this, and it's pretty easy to identify. Both are going to present with bilateral cataracts. If that's it stops there, then that's galactokinase. All right, then you have UDP galactose 4 epimerase deficiency, or uridyl diphosphate galactose 4 epimerase deficiency. This is a little bit more rare. It's a disorder that, compared to the uridyl transferase deficiencies, they can also have all the symptoms of galactose 1-phosphate uridyl transferase deficiency, but they also have, in addition to those, they can have hypotonia as well as nerve deafness. So that's something to look out for. Don't remember that being part of my exam, but it's one of those pearls that would be nice to just have in the back of your head, just in case. Give you that extra point. Next up, we're going to talk about the glycogen storage diseases. So here we have von Gueric's disease, Pompey's disease, Cory's disease, amylopectinosis, which is a type 4 glycogen storage diseases. We have liver phosphorylase deficiency. All right, so we're going to go into a little bit more detail on each one. So for von Gueric's disease, that's a type 1 glycogen storage disease. The deficiency here is a glucose 6-phosphatase in the liver and the kidney, and then the intestinal mucosa. So that's where it's going on. It's a deficiency of glucose 6-phosphate in the liver, kidney, and the intestines. This causes hypoglycemia, as well as lactic acidosis, hypertriglyceridemia, and hyperuricemia. And that's going to present, those symptoms are going to present, or signs are going to present at 3 to 4 months of age. But their liver transaminases are going to be normal. Also, hypoglycemic seizures can also occur. But the characteristic findings, how they're going to present, is an infant with a doll-like face. So they'll have flat cheeks. They can also have thin extremities, a short stature, a very protuberant abdomen. And that protuberant abdomen is obviously due to the enlargement of the kidneys and of the liver. But their spleen and their heart are going to be normal. So that's von Gueric's. So remember, it's a glucose 6-phosphatase deficiency in the liver and the kidney and the intestines. Can lead to hypoglycemia. They have normal transaminases, and they're going to have that doll-like face, which they'll describe with like a flat cheeks. So if they start describing the cheeks and getting in there, then start thinking von Gueric's. For Pompey's disease, this is a type 2 glycogen storage disease. Remember the whole Pompey is a problem with the pump from step 1. So the pump is going to be the heart, right? So in Pompey's disease, we have a deficiency of acid maltase. which is a lysosomal alpha-1,4 glucosidase, and a alpha-1,6 glucosidase deficiency. The 1,4 glucosidase is kind of easy to remember because you have 4 chambers in the heart. Alpha-1,4, Pompey's disease, problem with the pump. Presentation is within the first few weeks of life, and they present as a floppy baby. So floppy baby is a term they love to use. So Pompey's could be another differential for floppy baby, with feeding difficulties as well as macroglossia and heart failure. So if you see heart failure, floppy baby, and they're asking you what kind of enzyme deficiency, pick alpha-1,4 glucosidase, or if they tell you what's the disease, it's Pompey's, or what type of glycogen storage disease is the type 2. They're probably not going to ask you that. They might ask you the enzyme. All right, and so the floppy baby with the heart failure is due to progressive hypertrophic cardiomyopathy. Hepatomegaly could be also positive, and they can have exercise intolerance, obviously, because of the cardiac cardiomyopathy. And remember also that mnemonic, the Pompey trashes the pump. Example of the pump is the heart, obviously, but also the liver and the muscles. So whenever you have these glycogen problems, think of muscles, think of liver as well. But if they start pointing you in the direction of like a cardiac problem, it's Corey's. All right. I'm sorry, it's Pompey's. Now, Corey's disease is the next one. Sorry about that. That's a type 3 glycogen storage disease. And the deficiency for Corey's disease is a glycogen debranching enzyme, specifically alpha-1,6 glucosidase. So alpha-1,6 glucosidase, Corey's disease. The findings is going to be similar to von Gueric's because they're going to present with hepatomegaly, hypoglycemia, hyperlipidemia, as well as growth retardations. So that can make it difficult to distinguish initially. So different lab values from von Gueric's are going to be that in Corey's, they'll present with elevated liver transaminases, as well as a fasting ketosis, normal blood lactate, and uric acid concentrations are going to be increased, right? Other findings are going to be splenomegaly and normal kidneys. The kidneys are going to be normal. So Corey's alpha-1,6. For amylopectinosis, that's a type 4 glycogen storage disease. That's another debranching enzyme problem. And it presents within the first 18 months of life. And they present with hepatosplenomegaly, as well as failure to thrive, and they can progress to cirrhosis of the liver. That's very, very generalized, so they don't really ask that. I just put that as for completion's sake, but that's really not going to be, I mean, it's probably going to be a diagnosis of exclusion at that point on the vignette. So it's just a branching enzyme deficiency. I mean, Corey's is also a debranching enzyme deficiency, so it's not telling you much. And it comes with hepatosplenomegaly and failure to thrive with progressive cirrhosis of the liver. Well, I guess with the cirrhosis of the liver, that might point you in that direction, but just know that for completion's sake. For liver phosphorylase deficiency, this is a benign disease. They present with hepatomegaly as well as growth retardation early on in childhood. They can have very mild hypoglycemia, hyperlipidemia, and hyperketosis. They can have a normal lactic acid and uric acid levels. All right, moving on, we have the lysosomal storage diseases. And here, we're going to talk about sphingolipidosis. So like Fabry's and Gaucher's, and so on. Niemann-Pick's, Tay-Sachs. Okay, so Fabry's disease. Fabry's is an alpha-galactosidase deficiency. And this is an accumulation of ceramide trihexoside, sorry. So an accumulation of ceramide trihexoside and an alpha-glucosidase deficiency. It's excellent recessive, and this is characterized by angiokeratomas. They have peripheral neuropathy, and they can get asymptomatic corneal dystrophy. And the patients can also start developing heart failure, renal failure, and because of that, they're at increased risks of thromboembolic events. So Fabry's disease, that's the alpha galactosidase deficiency. Now for Gaucher's disease, this is a glucocerebrosidase deficiency. Glucocerebrosidase deficiency. So since the enzyme is deficient, glucocerebroside accumulates. And the presentation is an anemia with thrombocytopenia. They can get hepatosplenomegaly, osteoporosis, aseptic necrosis of the femur, as well as a bone crisis, and the Gaucher cells, right? Which, if they show you this, it's kind of like giving it away. They have a lipid-laden macrophage that has a crumbled like tissue paper. So, I mean, if they explain that to you, thank God, because that's about all I remember with Gaucher's. I used to think that Gaucher just sounds to me like one of those chocolates that has fancy wrappers, like a Ferrero Rocher or Gaucher's, Gaucher's. It sounds similar to me. So they have these fancy wrappers that are very crinkled. So that's the way I remember it. And so the crumpled up tissue paper, lipid-laden macrophages is how it looks like, or it's described as. But at this point, they've used that like a clue word. So may or may not present that way. If it does, great. If it doesn't, just remember that Gaucher's disease is a glucocerebrosidase deficiency, and because of that enzyme deficiency, glucocerebroside will accumulate. All right, now we're going to distinguish between Niemann-Pick and Tay-Sachs disease. In Niemann-Pick disease, it's a sphingomyelinase deficiency, and in Tay-Sachs disease is a beta-hexosaminidase A deficiency. So the way you can remember that is a Tay-Sachs beta-hexosaminidase A deficiency. Tay for A. And then Niemann-Pick is sphingomyelinase deficiency. You can pick your nose with your finger, right? Sphingomyelinase. Now, both of them, both Niemann-Pick and Tay-Sachs, are going to have Ashkenazi Jewish heritage, so that's not going to tell you much. And they're both going to be autosomal recessive inheritance. They both present between 2 to 6 months of age. So this is what they like. The next is what they're definitely going to test you on. Not the enzyme, but on their presentations, on their clinical features. Now, both of them are going to have loss of motor milestones. Both of them are going to give you hypotonia. Both of them present with feeding difficulties, and both of them have cherry red spots on the macula. Great, right? So it's like you still can't distinguish that. The way you distinguish that between Niemann-Pick and Tay-Sachs is that Niemann-Pick is going to have areflexia. They're not going to have reflexes. Versus Tay-Sachs are going to have hyperreflexia. It's just the way it is. So I really don't have a very good way of remembering those things. Drop a comment below if you have a good way of remembering that, but I guess, I don't know. I really don't know. So areflexic, Niemann-Pick's disease, sphingomyelinase deficiency. Tay-Sachs disease, they're going to be hyperreflexic, and it's a beta-hexosaminidase A deficiency. And they're all going to be Ashkenazi Jewish inheritance. They're both going to be autosomal recessive. Both present 2 to 6 months of age. Both have loss of motor milestones, hypotonia, feeding difficulties, cherry red spot on the macula, and hepatosplenomegaly. Oh, I'm sorry. No. Hepatosplenomegaly is also Niemann-Pick's disease. Tay-Sachs does not have hepatosplenomegaly. All right. And what makes it even more confusing is that both of them present with hypotonia. But Tay-Sachs is hypotonic, but they're hyperreflexic. Versus Niemann-Pick, they're hypotonic and they're areflexic. So I guess just try to memorize those two little key points. All right, so Niemann-Pick, there's 3 types of Niemann-Pick. There's Niemann-Pick type A, B, and C. Type A is going to be the most severe, and type B and C are milder forms of Niemann-Pick. Type A and B are caused by sphingomyelinase deficiency, and the sphingomyelin is going to accumulate. For Niemann-Pick disease, the type A is progressive. They have foam cells, which are your lipid-laden macrophages, which are also seen in Gaucher's disease, the lipid-laden macrophages. Niemann-Pick disease is also going to present with the protuberant abdomen, and they're almost universally fatal. Almost all of them are going to die by the age of 3 years old, unfortunately. There's no treatment yet, and the treatment is supportive, and that's all you can do for Niemann-Pick. For Tay-Sachs, this is lysosomes that have an onion skin, and they have the accumulation of GM2 ganglioside, so that's going to accumulate with Tay-Sachs. They're also going to have intellectual disability. They're going to have weakness as well as seizures. And then finally, we have Krabbe's disease, and that's a galactose cerebrosidase deficiency. So what's going to accumulate is galactose cerebroside and something called psychosine that accumulates. Krabbe's disease is also autosomal recessive. It presents early on in infancy with developmental regression, hypotonia. They can get areflexia as well as peripheral neuropathy, and optic atrophy, as well as globoid cells, so the cells look really big. And in Krabbe's disease, they also have cherry red spots on the macula, and but organomegaly may not be present. The cherry red spot in the macula, they could have it, or they may not have it. So just one thing to take home here is that cherry red spots on the macula really don't tell you much of anything anymore. All I can tell you is it can narrow it down to either Krabbe's, Niemann-Pick, or Tay-Sachs. So, and then just follow on reading to see if you can pick up on something else. All right, so next up, we're going to talk about the mucopolysaccharidoses. These are like Hurler syndrome. And so for Hurler syndrome, this is an alpha-L iduronidase deficiency. It's a lysosomal hydrolase deficiency. And what is going to accumulate, they might ask, is heparan, not heparin, heparan sulfate and dermatan sulfate. Those two increase. And these present also between the ages of 6 months to 2 years old. With Hurler syndrome, they have coarse facial features. They have inguinal or umbilical hernias, as well as corneal clouding with hepatosplenomegaly. So they have like that gargoyle-looking face from step 1. And I don't know why I didn't put in here Hunter's syndrome, because Hurler's and Hunter's are always together. But a hunter, you need your eyes to see the target, so they don't have corneal clouding. Versus Hurler's, they do have corneal clouding. And also the distinguishing features is that Hurler syndrome, they have that coarse facial features. They're kind of so ugly it makes you want to hurl. That's the way it works, or how I remember it. It doesn't work that way, it's just the way I remember it. All right, next up is common causes of intellectual deficiency. So they love to ask these, and the most common one is going to be fetal alcohol syndrome, followed by Downs and Fragile X syndrome. So those are the 3 most common causes of intellectual disability. Obviously, fetal alcohol is going to be number 1. There's a lot more pregnancies with women who've drank during the pregnancy causing a fetal alcohol syndrome than there is a bunch of Down syndrome in the world. So that's a way I remember it. So fetal alcohol syndrome, their face has a smooth philtrum. There's a thin vermilion border, and they also have small palpable features as well as microcephaly. The smooth philtrum is, I mean, that's a given. Fetal alcohol syndrome. For Downs, the face, they're going to show flat facial profiles, slanted palpebral fissures. They can have a small, low-set ears. On the body, they can have excessive skin at the nape of the neck. They can have that single transverse palmar crease, clindodactyly, as well as large spaces between the first two toes. And then finally, Fragile X syndrome. On the face, they have a long, narrow face. They have a prominent forehead and chin. They have large ears and macrocephaly. And their body, they're going to have macroorchidism. So their testicles will be very large. And they have large ears, long, narrow face. But their IQ could be either normal or low, and that results from a full mutation in the FMR1 gene, and that's caused by an increased number of the CGG, trinucleotide repeats. They love to ask that, the CGG, and that's accompanied by an aberrant methylation of the FMR1 gene. So FMR1 stands for Fragile X Mental Retardation Gene 1, right? So fetal alcohol syndrome, this can result in no apparent sequelae or from other fetuses. Others may suffer from fetal alcohol syndrome or be stillborns. You want to advise pregnant women and those planning on conceiving to completely abstain themselves from alcohol, as there's no known safe amount for prenatal alcoholic consumption. Causes of birth defects and neurodevelopmental problems can happen with fetal alcohol syndrome. Height and weight growth are going to be compromised with percentiles that are going to lead to like less than 10th percentile for age and sex, as well as cognitive and behavioral disorders. The phenotypic range of neurodevelopmental problems is wide, and it's going to include intellectual disability, as well as attention deficit hyperactivity disorder, ADHD, social withdrawal, and delays in motor and language milestones. Early diagnosis is critical for affected children to benefit from an aggressive speech, physical, or occupational therapy. Next up, we have sudden infant death syndrome, and there's going to be two types of factors here: maternal factors and infant factors for sudden infant death syndrome. Maternal factors are going to be smoking during or after a pregnancy, if they're younger than 20 years old, and if they have inconsistent prenatal care. Those are all risk factors from the mom for causing sudden infant death. How do you prevent sudden infant death maternally? You want to advise them to stop smoking during and after the pregnancy, and you want to tell them to constantly come in for prenatal care. Now, infant factors, risk factors for sudden infant death syndrome, would be if they sleep prone or on the side, soft sleeping surfaces, so no comfort pillows and no fluffy gooseneck feather comforters here for the baby, as well as loose bedding, right? They can wait later on in life. For now, it's hard surfaces. Bed sharing is obviously not good. Prematurity, and a sibling with sudden infant death syndrome as well. So those are infant risk factors. How do you prevent it? You tell the mom to have the baby sleep in a supine position. You want a firm sleep surface, and you want to avoid sharing the room with somebody else, and you want them to avoid using pacifiers. Now, to avoid suffocation, avoid the loose bedding. You can actually put crib bumpers, and soft mattresses are just not advised as well. So next up is cerebral palsy. cerebral palsy, the risk factors here is obviously prematurity. They love to ask that on Uworld. I remember that. So prematurity is going to be one of the number one causes of cerebral palsy, and that's if they prematurity, remember, is always before 32 weeks. Also, intrauterine growth restrictions can cause cerebral palsy, intrauterine infections, antepartum hemorrhages, placental pathologies, multiple gestations, maternal alcohol consumption, as well as maternal tobacco use. The way you manage is with physical, occupational, and speech therapy. You can give baclofen and botulinum toxin for spasticity. And the comorbidities for cerebral palsy would be an intellectual disability. That's the most common, 50%. As well as epilepsy. They can get strabismus and scoliosis. Cerebral palsy is basically a group of clinical symptoms that are syndromes that are characterized primarily by non-progressive motor dysfunction. There's three primary subtypes. There's spastic cerebral palsy, a dyskinetic, and ataxic. And it's often multifactorial in etiology. For the spastic diplegia, this is a form that's most commonly seen in premature infants, and it's characterized by two things, by hypertonia and hyperreflexia. That's going to predominantly involve the lower extremities as well as both feet that point down and inward, so the echinovarus deformity. And spastic diplegia is also going to present characterized by a resistant to passive muscle movement, which increases with more rapid movement of the affected extremity. That's the clasp knife diagnosis, right? So many patients are going to suffer from vision, hearing, speech, and other impairments. All right, next up is going to be hydrocephalus. So for hydrocephalus, these are infants. Infants with the hydrocephalus can present with the following findings. So symptoms could be like poor feeding, irritability, decreased activity, and vomiting. Physical findings include a tense and bulging fontanelle, prominent scalp veins and a widely spaced cranial sutures, rapidly increasing head circumferences as well. So all those things are findings in hydrocephalus. The way you evaluate it is a symptomatic patient that has a rapidly increasing head circumference. So they're going to show you a growth chart, obviously, and they'll present you with a growth chart that their head circumference keeps increasing normally by age, and suddenly you see a huge spike that goes up. What do you do next? What is the best initial test? And that's going to be a CT scan. So the CT scan is going to reveal ventricular dilation and on the infant's anatomy. So it's stable and asymptomatic infant is going to be they're going to require a sedated MRI to spare the patient from radiation. And both CT and MRI can provide much greater detail than an ultrasound. So that requires widely open anterior fontanelles and is most useful in infants under 6 months of age. How do you treat hydrocephalus? Obviously with a shunt that's going to be placed from the ventricles to the peritoneum, pleura, or the right atrium. So it's a shunt that's just basically going to drain into those places, to the right atrium, the pleura, or the peritoneum. All right, next up is acute causes of hemiplegia in children. So there's various causes of hemiplegia. You have seizures, intracranial hemorrhages, ischemic strokes, hemiplegic migraines. So for seizures, they'll have a history of generalized limb jerking or loss of consciousness. They can have presence of post-ictal confusions like Todd's paralysis that we're going to go into later. Symptoms are going to self-resolve with the seizures in a hemiplegia with children. So the next up is intracranial hemorrhages can also be an acute cause of hemiplegia in children. They're going to have a history of trauma or bleeding disorders like hemophilia, or signs of increased intracranial pressure like vomiting or bradycardia. Also, another cause of hemiplegia would be like an ischemic stroke, and these are a history of prothrombotic disorders like antithrombin 3 deficiency or cardiac diseases. So like a patent foraminovaly, and focal neurological deficits like hemiplegia, aphasia, and ataxia. These are all acute causes of hemiplegia in children. For a hemiplegic migraine, that's another cause of hemiplegia in children. The onset is in adolescence, and it often has a positive family history. There's going to be a history of headaches and visual auras, but the symptoms self-resolve. So moving on, we have Todd's paralysis. So this is a self-limited focal weakness that occurs after you have a focal or a generalized seizure. So it's a type of paralysis that happens after the seizure. It presents in the post-ictal period with a partial or complete hemiplegia that involves an ipsilateral upper and lower extremity, although one may be more affected than the other. So the presenting signs can also include aphasia and visual defects. The pathophysiology for Todd's paralysis is really unknown, and it is hypothesized to involve neuronal exhaustion or inhibition of the postictal period. And the diagnosis is going to be based on the history alone. However, other causes of paralysis like an embolism or intracranial bleeding should be ruled out with a CT or an MRI if there's no clear history of a preceding seizure present. And the treatment for a Todd's paralysis is supportive, usually goes and resolves on its own within 36 hours. So that's Todd's paralysis. If you see a paralysis after a seizure, Todd's paralysis. Pretty easy. Next we have seizures. So these are classified as either focal or generalized seizures. So you have absence seizures, tonic-clonic seizures, myoclonic seizures. These are based on whether there's an abnormal neuronal discharge that can cause a seizure that originates from one or both hemispheres. So how do you approach seizures in children? So this is a small, fast algorithm on how to approach a seizure in a child. So if the child has a seizure activity and you see that it's appearing in both hemispheres of the brain, then that's a generalized seizure. If it only appears on one part of the brain, or one hemisphere of the brain, that's a partial seizure. So generalized, it involves both hemispheres. Partial involves only one hemisphere. Okay, so if it's both hemispheres involved, it's generalized. So three things. It can have loss of consciousness, can have bilateral motor findings, and it can be convulsive or non-convulsive, like an absence seizure that's non-convulsive. If it's a partial seizure, meaning that only one hemisphere of the brain is involved, then that's subdivided into either simple partial seizure with generalization, or complex partial seizures. For a simple partial seizure, this means that there was no loss of consciousness. There's feelings of familiarity, right? So that déjà vu feeling. And they could have an aura. And patients may remember, they can actually remember the event very well. That would be a simple partial seizure. Now for partial seizures with generalization, this is always kind of confusing, because both partial seizures with generalization and complex partial seizures both present with loss of consciousness. Now the partial seizure with generalization, on top of loss of consciousness, they can also have tonic-clonic activity, and this can lead to diffuse muscle aches, an increase in CPK. That increase in CPK, creatinine phosphokinase, is going to indicate a tonic-clonic activity. They can also have a history of tongue biting, loss of bowel and bladder control, and all those indicate a secondary generalization. All right, so if you're looking at kind of like the classic picture of a seizure, it's most likely going to be a partial seizure with generalization, where they lose consciousness, have a tonic-clonic activity, and then get muscle aches, increase in CPK, bite their tongue, lose their bowel and bladder controls. That's partial seizure with generalization. Now, complex partial, these also have losses of consciousness, but they can also have an aura. They can also have motor automatisms, like chewing, swallowing, or sucking. And sometimes they can have bilateral motor findings. So if you see somebody who's just like moving their lips or chewing, or they're constantly swallowing, that could be a sign of a complex partial seizure. All right, so focal seizures. Focal seizures, by definition, they originate from only one cerebral hemisphere, and they may or may not have loss of consciousness. The types of focal seizures can be divided in either motor, sensory, autonomic, or psychic. So the motor symptoms, or the motor type, they'll present with a Jacksonian march, and they can turn their eyes, their head, or their trunk. For sensory types of focal seizures, they can have paresthesias, vertigo, or visual phenomenon. For autonomic focal seizures, these are going to present with sweating, epigastric rising sensation, kind of like that sensation where you get where you're falling or you're going downhill very quickly or very steeply, and you feel like your stomach's coming up. Epigastric rising sensation. And then psychic types of focal seizures, you have deja vu, which affects affective changes like fear can happen. So focal seizures, they come from one hemisphere, and they may or may not be subsequently involved with two hemispheres. And it's classified by the presence or absence of impairment of consciousness. So impairment of consciousness may or may not be there. A focal seizure with impairment of consciousness previously known as a complex partial seizure, and it cannot respond to stimuli during the episode. There's repetitive semi-purposeful movements like chewing, sucking, and swallowing. Those are called automatisms. These involve both hemispheres and are seen in focal seizures with impairment of consciousness. Remember that term, focal seizure with impairment of consciousness, because that's the new term. Before was complex partial. Now it's focal seizure with impairment of consciousness. School-age children, which can have subtle presentations, can present with a decline in school performance. They can have a post-ictal state that lasts several hours, but those can be seen in both complex partial seizures and partial seizures with secondary generalization. And on EEG, you'll have an abnormal electrical activity that's going to be sustained with a distinct start and stop different from the patient's background EEG. An aura, they can have like an olfactory hallucination that indicates an origination from one hemisphere. The focal seizure without impairment of consciousness, these patients are going to be having a seizure while remaining awake, alert, and responsive. It's kind of weird, but it's kind of easy to define focal seizure without impairment of consciousness. It's like I could be seizing right now for all we know. Just kidding. So focal seizures are not provoked by hyperventilation. And then the treatment for a focal seizure is going to be like phenytoin. And phenytoin is going to be the drug of choice for all partial seizures. Now, generalized seizures are going to be like your absence seizure, which is also known as your petit-mal seizure. For an absence seizure, the clinical features they love to ask about absence is that there's a sudden impairment of consciousness, like staring spells. Their muscle tone is preserved, though, and they have unresponsiveness to tactile or verbal stimulation. So if you touch them, you're like poking them, hey, what's up? What's going on? Are you all right? They won't respond to you. However, the absence seizure, the duration is going to be very short, like around less than 20 seconds. They can have simple automatisms that are frequently present, so they can also have the lip smacking, the swallowing, stuff like that. And it's also easily provoked by hyperventilation. So if they're doing something that requires them to hyperventilate, like working out, working in the backyard, doing something, and suddenly they have to just sit down and they start staring into space, they're most likely might be having an absence seizure. The diagnosis is made with an EEG, and this is just another clue. If you have to remember 3 Hertz spike and wave discharge during an episode. If you hear that term, they're talking about an absence seizure. So an EEG with a 3 Hertz spike and wave discharge during the episode, that's an absence. Comorbidities for absence seizures are going to be like ADHD as well as anxiety. And the treatment is very important too, because here it's very specific. It's ethosuximide. That's first line treatment for absence, ethosuximide. Second line is going to be valproic acid. Side effects here would be like hair loss, tremors, and thrombocytopenia. But ethosuximide is going to be it. And absence seizures, since they are generalized, they're going to be coming from both cerebral hemispheres, and this usually occurs in children. So if they're going to present you with a case of absence seizures, it's going to most likely be a child within the ages of 4 to 10. And if you ask them about the event, they're not going to remember anything. It can occur infrequently or up to 100 times a day, and it can also happen without any type of trigger. It really sucks. Now, the automatisms, like the eye fluttering and the lip smacking, that can also be present, like we said, and it's most consistent with absence seizures, but it's not more complex events. And it can be misdiagnosed as an ADHD or normal childhood staring spells. You know, when a kid will just like sit down and just stare into a wall or stare out into space. They might not be having a seizure, they just be having a staring spell. All right, and then clinical features of absence seizures and inattentive staring spells. So since it's a very, very closely resembled diagnosis, absence seizures are going to occur during all activities. Their length, the time an absence seizure takes place is less than 20 seconds. They can have lack of response to vocal or tactile stimulation, and there are presence of automatisms. Versus inattentive staring spells, these occur primarily during very boring activities, like if they have to read or read some kind of boring thing, or maybe in a boring class, or just doing something that's boring. Also, variable length. It can be more than a minute for all we know. They do have responses to vocal or tactile stimulation, and they also obviously lack automatisms. So yeah. And then we have juvenile myoclonic seizure, which presents with generalized seizures during adolescence. It's most commonly, they have myoclonic jerks, and that happens within the first few hours after awakening. Absence seizures and generalized tonic-clonic seizures can also be seen with a juvenile myoclonic seizure. And the first-line treatment for juvenile myoclonic seizure is lorazepam, and that's for prolonged seizures and for status epilepticus. All right, next up is febrile seizures. And febrile seizures, the risk factors here are obviously fever, from mild fever, like from a viral infection such as influenza, adenovirus, also HHV6, or any bacterial infection. Also, immunizations can cause febrile seizures, like the diphtheria, tetanus, acellular pertussis, so the DTaP, the MMR, as well as family history of febrile seizures. Those are all risk factors. Diagnostic criteria would be a febrile seizure is usually between 6 months to 6 years old. Temperature, you're going to see temperatures of above 100.4 degrees Fahrenheit. There's no history of previous afebrile seizures or no CNS infections, and no acute systemic metabolic cause of a seizure. Now, seizures or febrile seizures are subtyped between simple and complex. So for a simple seizure, that could be non-focal, where you have your tonic-clonic or atonic seizure. The first episode is going to last less than 15 minutes, or you can have multiple episodes that are less than 30 minutes for simple seizures, simple febrile seizures. So complex febrile seizures are going to be focal, and they're going to last more than 15 minutes if it's one, or multiple ones lasting more than 30 minutes. And the management for febrile seizures is going to be abortive therapy if the seizure is more than 5 minutes, as well as reassurance and education, because the fever is just going to pass, and as soon as the fever passes, the seizure will pass as well. Prognosis is there's going to be a normal developmental or intelligence. There's around 30% risk of reoccurrence when you have a febrile seizure. That's why a family history or a previous history of a febrile seizure is a risk factor, and less than 5% risk of epilepsy. So this has very little to do with epilepsy. It's common and it's generally harmless cause of exclusion, and it's a cause of concern in children, and most are just short and do not cause any type of brain injury. For simple febrile seizures, the multiple studies have shown that interventions such as imaging or lumbar puncture in the fully vaccinated child with a normal neurological examination are low yield, and it's unnecessarily invasive and anxiety provoking. It can be simple febrile seizures, the patient can be discharged home with education about the seizure precautions and supportive care like hydration for the concurrent infection. And caregivers should be informed that antipyretics can make the child more comfortable, but there's no evidence that these will actually reduce the risk of a future febrile seizure. Now, for a complex febrile seizure, the brain image should be considered in a child with a complex febrile seizure, with a persistently abnormal neurological examination, if they have macrocephaly, or if they have signs and symptoms of elevated intracranial pressure. Now, for Lennox-Gastaut syndrome, this typically presents by the age of 5, and they present with intellectual disability as well as severe seizures of varying types. So they can have atypical seizures, they can have absence, or they can have tonic seizures. And the EAG for Lennox-Gastaut syndrome is going to be a slow spike and wave pattern. So slow spike and wave pattern, Lennox-Gastaut, and the 3 Hertz spikes and waves are going to be absence. Okay, so just remember, slow spike and wave is going to be Lennox-Gastaut. Features of non-accidental trauma, there's going to be a history of vague or changing details, injury inconsistent with a child's developmental stage, and a sibling that's described as responsible. On examination, there can be injury that's inconsistent with the history. They'll show multiple fractures or bruises in different healing stages, and it's likely to be inflicted, these injuries, like cigarette burns. A poorly kept child is what you would see on exam, with bruises on the neck, on the abdomen, or in very unusual sites. There's also can be injury to the genitalia, injury to the hands and the back, or in the buttocks. And the caregiver's behavior, the caregiver would possibly show up as being argumentative or violent. There can have a lack of emotion or interaction with the child. There can be an inappropriate response to the child's injury and inappropriate delay in seeking medical care, and also a partial confession in causing the injury. So they're not going to fully confess to doing the injury, so you just have to listen very carefully at what they're describing. So, for instance, shaken baby syndrome, that's the most common form. It's a subdural bleeding due to rupture of the bridging veins. They like to ask that one. It's rupture of the bridging veins and retinal hemorrhages. And because of that, this can lead to seizures. And that seizure can cause an increase in head circumference, or the hemorrhaging can cause an increase in head circumference. They can have bulging of the anterior fontanelle, as well as altered mental status. And in that case, a non-contrast head CT and skeletal survey is done, and you want to admit the patient to protect the patient from the caregiver, and you want to inform Child Protective Services. So those are all features of non-accidental trauma. So these are forms of child abuse. Okay, so traumatic carotid injuries. So for traumatic carotid injuries, its mechanism, they can present as having a penetrating trauma to the carotids, a fall with an object in the mouth. That's the way they like to explain it in Uworld. Some kid goes and he's running around and he falls and a pencil gets shoved in his mouth, or a toothbrush, or any kind of neck manipulation like some kind of contact sports or even yoga can lead to traumatic carotid injuries. The presentation for a carotid injury would be a gradual onset of hemiplegia, aphasia, neck pain, and a thunderclap headache. And the diagnosis is done with a CT or MR angiogram. There's injury to the posterior pharynx, and that can cause the injury to the cervical internal carotid artery, which is located directly lateral and posterior to the tonsillar pillars. So that's the problem with the falling with a toothbrush in your mouth or a pencil. It's going to go and actually cause damage to that internal carotid artery, causing a thrombus formation. And that can extend on to the middle cerebral artery and the anterior communicating artery, or anterior cerebral artery. So next up is head trauma in children between the ages of 2 to 18. So that's pretty much the whole entire child span, right? So evaluation of head trauma in children ages 2 to 18. So the clinical scenario here is like any of the following: if they have focal neurological findings, if they have skull fractures, especially signs of basilar skull fractures, like the raccooing of the eyes and stuff, seizures and persistent altered mental status, agitation, lethargy, slow response, and prolonged loss of consciousness, what you'd want to recommend at that point, if you see any of that, is to do a head CT without contrast. Without, because you're thinking that it's a severe traumatic brain injury. Also, if the Glasgow Coma score is 15 with any of these following, so if they have a Glasgow Coma score of 15 with vomiting, headache, questionable brief loss of consciousness, injury causing high-risk mechanism injury, and severe mechanism injury, its recommendation there is preference to the clinician. So because these are all mild traumatic brain injuries, you can do a head CT without contrast, or you can just simply observe them for 4 to 6 hours. Now for minor head trauma, that's a Glasgow Coma score of 15 with non-severe mechanisms like no vomiting, no headache, no loss of consciousness, or any types of fractures. Then you don't need a head CT. It's a minor traumatic brain injury. In that case, you just observe or send them home. Now, so a little bit more on severe traumatic brain injury. This requires neuroimaging. Also, it requires close inpatient monitoring, like neurological examinations every 2 hours, and neurosurgical consultations, and they typically have significant intracranial injuries. For minor traumatic brain injury, examples would be like concussions, a Glasgow Coma scale between 13 to 15, also loss of consciousness that occurred less than 5 minutes, altered mental statuses at the time of the injury, loss of memory like amnesia before or after the injury for less than 24 hours. And if the clinician prefers to observe those symptoms, they prefer to observe them because the symptoms can deteriorate, and if that's the case, then a CT should be performed. The patient can be discharged home with a reliable caretaker if a CT scan is normal or if there is any type of improvement during observation. And clear written instructions with return precautions should be provided to the patient. Potential risks of cancer from a CT scan, associated radiation increases with decreasing age. So 1 in 1,500 if they're 1 year of age, or 1 in 5,000 if they're 10 years old. So you have higher risk if the younger you are. The older you are, you have a little bit less of a risk. All right, cool. So now we're going to talk about types of cranial hematomas. So so here we got like caput succedanum and cephalohematoma. These are really commonly tested. For the caput succedanum, caput is a diffuse and sometimes ecchymotic swelling of the scalp. It usually involves the portion of the head that's presenting during vertex and delivery. So that's the actual caput. It may extend across the midline and across the suture line. So if it crosses the midline and suture lines, that's a caput. Okay. Now cephalohematoma, this is a subperiosteal hemorrhage, and it's always limited to one cranial bone. There's no discoloration of the overlying scalp, and swelling is usually not visible several hours after birth, because the subperiosteal bleeding is going to be a slow process. So because it's slow, you won't really see it in a couple of hours. You'll see it probably in days to weeks. In most cases, do not require any treatment because they will respond spontaneously within 2 weeks to 3 months, depending on how bad it is. But rarely phototherapy is needed to improve the hyperbilirubinemia, because you will get hyperbilirubinemia due to red blood cell hemolysis, right? All right, next up is meningitis. Meningitis is a long-term neurological sequelae that's associated with the bacterial meningitis. So they're going to have hearing loss, loss of cognitive functions due to the neuronal loss in the dentate gyrus of the hippocampus. So that's kind of remember that it's loss of cognitive function in the dentate gyrus of the hippocampus. They also present with seizures, mental retardation, as well as spasticity or paresis. For muscular dystrophies, all right, so there's a couple of different muscular dystrophies. You have Duchenne's, you have Becker's, and you have myotonic. So Duchenne's and Becker's, both of them are going to be X-linked recessive deletion of the dystrophin gene that's located on chromosome XP21. It's kind of need to remember that, because it can present you with either or, but they're going to ask you what chromosome is involved. It's XP21, and it's a deletion of the dystrophin gene. All right, versus myotonic muscular dystrophy, that's autosomal dominant, and that's an expansion of a CTG trinucleotide repeat in the DMPK gene on chromosome 19q13.3, if you can remember that. So CTG trinucleotide repeat, DMPK gene, chromosome 19q13.3. At that point, they're pointing you in the direction of a myotonic muscular dystrophy. Versus deletion of the dystrophin gene on chromosome XP21, that's either Duchenne's or Becker's. Now, clinically, how do they present? So in Duchenne's, they're going to present earlier on than in Becker's. Duchenne's going to present with progressive weakness, a Gowers maneuver, and calf pseudohypertrophy. And then Becker's is going to be even milder clinical presentation with mild weakness compared to Duchenne's. So Duchenne's is going to be a little bit worse, and it happens at a younger age, 2 to 3 years old, versus Becker's is going to happen at between 5 to 15 years old, but it has mild weakness and mild clinical presentation. For myotonic muscular dystrophy, the onset of age is between 12 to 30. They also have facial weakness, hand grip myotonia, as well as dysphagia. Some of the comorbidities on Duchenne's would be like scoliosis and cardiomyopathy, versus Becker's is going to have cardiomyopathy. So again, Duchenne's is going to be a little bit more severe with the added on scoliosis. So if you can see that pattern, Duchenne's is going to be worse than Becker's. And then myotonic, the comorbidities would be arrhythmias, cataracts. They can have balding as well as testicular atrophy and infertility. Now, Duchenne's are going to be wheelchair dependent by the time they're in adolescence. And they're going to unfortunately die by the ages of 20 to 30 years old. And they're going to die of respiratory or heart failure. So problems with the muscles, right? The diaphragm or the cardiac muscle. Becker's, they're going to at least live a little bit longer, and they'll die between the ages of 40 to 50, specifically from heart failure. And then myotonic muscular dystrophy, that prognosis is going to be death from respiratory failure, and that's going to just depend on when is it that they got the actual the disease. So it's depending on the age of onset. So myotonic muscular dystrophies, it could be subdivided into different types. Type 1 being the most common. That's the Steinhardt disease. And it's most common adolescent adult onset muscular dystrophy, and it affects around 1 to 8,000 people in the US. Now the gene involved, remember we said it was the DMPK gene, that stands for dystrophia myotonica protein kinase gene. So that kind of helps you out. The dystrophia myotonica, or myotonic dystrophy, right? That's kind of easy if you can just remember that. Protein kinase gene. Causes would be myotonia, weakness in the skeletal muscles, smooth and cardiac muscles, those problems in multiple organs. The myotonia is going to be a delayed muscle relaxation. So most notably, it's when the patient is unable to release their hand after a handshake. So that's like grip myotonia, and that's the way they like to ask you on the exam. Maybe even I don't recall having an actual question on my exam on that, but they do like to ask that way in the Uworld question bank, where they'll have a patient who has a difficult time unable to release their hand after a handshake. That's myotonia, or a myotonic muscular dystrophy. Skeletal muscle weakness is going to be prominent in the face, in the forearms, and the hands, as well as in the ankle when they try to dorsiflex. So in that case, they'll have bilateral foot drop. There's also smooth muscle weakness like dysphagia, and that's the most dangerous manifestation because that can lead to an aspiration pneumonia. And also myotonic muscular dystrophy is also associated with insulin resistance. Myotonia, here's a little thing that I wrote here to help you remember. Myotonia, my testicles, testicular atrophy. Myotonia, my toupee for frontal balding, and myotonia and my ticker for arrhythmias. So maybe that'll help you. Friedreich's ataxia, this is another one. It's autosomal recessive. It's an excessive number of the trinucleotide repeat sequence, causing an abnormality of the tocopherol transfer protein. There's a progressive form and a poor. The prognosis is very poor. On CNS, you'll have decrease in vibration as well as position sense in the lower extremities. They'll present with a wide base gait, high plantar arches, with bilateral absence of ankle jerks. And most patients are going to be wheelchair bound by 25 years of age, and death does occur by age 30 to 35 years. An MRI of the brain and the spine is going to show marked atrophy of the cervical spine and cerebellar atrophy. In the heart, there's going to be necrosis and degeneration of the cardiac muscles that can lead to myocarditis. And that shows up on EKG like a T-wave inversion. So remember that. T-wave inversion is myocarditis. Myocardial fibrosis as well, and cardiomyopathy. Also in the heart, it can lead to cardiac arrhythmias and CHF, and that can lead to significant numbers of death. An MI, myocarditis, old pericarditis, myocardial contusions, and digoxin toxicity are all related to T-wave problems. And in families with one affected child, genetic counseling is recommended for prenatal diagnosis. All right, moving on, we have neurocutaneous disorders like Sturge-Weber syndrome and tuberous sclerosis, as well as neurofibromatosis. So let's start off with Sturge-Weber syndrome. They present with focal or generalized seizures, and that's usually neurological presentations, and they can present at any age. They can have mental retardation, as well as the port wine stain or the nevus flammeus in the distribution of the trigeminal nerve, so if you can remember that. And it also represents with a congenital unilateral cavernous hemangioma that does not blanch when you apply pressure. So port wine stain is one that they like to ask. Hemianopia as well, hemiparesis. They can have hemisensory disturbance and ipsilateral glaucoma. And skull x-rays are going to be taken after 2 years of age. Then that's going to reveal a gyriform intracranial calcification that does resemble a tram line. And the treatment, that's going to be aimed at controlling the seizure and reducing intraocular pressure. Specifically, this therapy called an argon laser therapy, that's successful in removing the skin lesions for the neurocutaneous Sturge-Weber syndrome. For tuberous sclerosis, this is a neurocutaneous genetic syndrome that has two types of genes, the TSC1 and TSC2. That stands for tuberous sclerosis 1 and tuberous sclerosis 2 genes. And it's associated with intracranial tumors like cortical tubers, hamartomas, subepidemial giant cell astrocytomas, and subepidemial nodules that can basically cause an initial presentation of a seizure. For cutaneous lesions, these are called adenoma sebaceum. Those are the cutaneous lesions, adenoma sebaceum, and those appear at 5 to 10 years of age. And additional characteristics are going to include hypopigmented nodules or macules, known as ash leaf spots. So those are hypopigmented nodules or macules. They can also present with facial angiofibromas, cardiac rhabdomyomas, and renal angioleiomyomas, as well as mental retardation. So there's two types of neurofibromatosis. There's type 1 and type 2. So type 1, that's your von Recklinghausen disease, versus type 2, which is essential neurofibromatosis. So for neurofibromatosis type 1, the gene mutation is a tumor suppressor gene mutation that codes for a protein called neurofibromin. It's located on chromosome 17, and for neurofibromatosis type 1, they present with your classic café au lait spots, multiple neurofibromas, as well as Lisch nodules. So the way I remember it is that neurofibromatosis type 1 looks more classical. So you'll have neurofibromas for neurofibromatosis. You'll have your café au lait spots and your Lisch nodules, right? So if you can remember that, classic signs, that's type 1. And that's the way they're going to present you with the main clinical features. Now for type 2, central neurofibromatosis, this is a tumor suppressor gene NF2, which codes for the protein Merlin. So I don't know if they like to ask that, but just remember type 2 is for Merlin, type 1 is for neurofibromin. Type 2 is also has another 2, the number 2 sequence, so chromosome 22, and bilateral acoustic neuromas. So bilateral meaning both, 2 ears, bilateral acoustic neuromas, and cataracts, 2 eyes, 2 ears, 2 cataracts, bilateral acoustic neuromas, chromosome 22 for the NF2. So if that makes any sense, try to remember it that way. So for neurofibromatosis type 1, remember the café au lait spots. Those are going to be your earliest manifestations, and those can occur in infancy. It's going to increase with age, and you'll see axillary inguinal freckles, Lisch nodules, which remember the Lisch nodules are hamartomas in the iris, and neurofibromas, which are benign nerve sheath tumors. There's a risk of intracranial tumors like optic pathway gliomas, and that's the most common type of intracranial lesion, and it typically manifests during toddlerhood. Macrocephaly, feeding problems, as well as short stature and learning disabilities, are found in neurofibromatosis type 1. An MRI of the brain and in the orbit, that's going to be the best modality for a very detailed evaluation of the soft tissue anatomy in any neurofibromatosis type 1 patient. That's going to be concerning with neurological symptoms. So neurological symptoms like chronic headache, visual changes, early morning vomiting, and it's preferred over a CT to do that, to do the MRI. All right, so next up is capillary hemangioma, and these are way less severe. They present at birth and appear by 6 months of age. They consist of very small capillaries and present as an irregular raised lesion that blanches on pressure. And approximately 75% of these capillary hemangiomas, they go away by 7 years of age. So that's benign. Now, neuroblastoma is the next one. And for neuroblastomas, it's the most common extracranial solid tumor of childhood. It's the third most common tumor in the pediatric population after a leukemia and after CNS tumors. And the mean age of diagnosis is at 2 years of age. It could arise from the neural crest cells, which also give rise to an adrenal medulla, and the sympathetic chains. So the tumor itself can arise from the adrenal medulla and the paravertebral sympathetic chains. So the most common site is going to be in the abdomen, specifically in the retroperitoneal ganglia, because it's part of the neural crest cells from the adrenal medulla, right? So the neuroblastomas are firm and they have nodular consistencies. They can present with calcifications and hemorrhages that are seen on plain X-ray and on CT scan, so they might throw that into the question. They'll give you a vignette where the patient, whether you see calcifications on X-ray or hemorrhages. 70% have metastasized by the time of the diagnosis. So if you're presented with a test question that you're suspecting a neuroblastoma, know that 70% of the time they have already metastasized at that point. Common metastatic sites are going to be the long bones, the skull, the bone marrow, the liver, the lymph nodes, as well as the skin. And on labs, you're going to see a serum and urine catecholamines and their metabolites. So the HVAs and the VMAs are going to be elevated. And those are elevated, but it's not due to, it's not going to cause any kind of fainting spells, sweating, palpitations, and they're not going to have hypertension. All those are seen in a pheochromocytoma. So just be aware of that. The prognosis is going to depend on the clinical factors like the histology of the tumor, the genetic characteristics like if they have amplification of the NMYC proto-oncogene, as well as hyperdiploidy. So remember that NMYC proto-oncogene. Wilms tumor arises from the metanephros, and they can also be precursors of the renal parenchyma. Remember that the mesonephros gives rise to the seminal vessels, the epididymis, as well as the ejaculatory ducts and the ductus deferens. And the paramesonephros, that's going to give rise to the fallopian tube, the uterus, and parts of the vagina. And finally, we're going to be discussing CNS tumors. So the most common CNS tumor is going to be your astrocytoma in children, the pilocytic low-grade astrocytoma. And that usually presents with seizures, and those seizures are longer duration seizures, as well as the symptoms are longer duration. They have contrast. The contrast enhancement is less likely, and the most common, it's the most common tumor of the posterior fossa, as well as the cerebral hemispheric tumor in children. And it's more commonly found in the lateral cerebellar hemispheres. So try to remember that it's found most commonly in the lateral cerebellar hemispheres. The medulloblastoma is going to be the second most common posterior fossa tumor in children after that cerebellar astrocytoma. So first is the cerebellar astrocytoma, followed by number 2 is your medulloblastoma. Now the medulloblastoma, the location are found most commonly in the cerebellar vermis. And that's responsible for gait and balance. So they'll have truncal or gait instability. So if you see in the vignette that the child or the patient is having weird gait there, try to think that it's in the cerebellar vermis. Less common sites would be like the cerebellar hemispheres, which affect fine motor planning and cause dysmetria, an intention tremor, and the dysdiadokinesia. It's close to the fourth ventricle. The medulloblastomas are close to the fourth ventricle, and they can cause an obstructive hydrocephalus. And the way that presents, obviously, is with signs of increase in intracranial pressure. They can have a potential of a leptomeningeal spread, so they'll have a drop metastasis. And the treatment here is to aggressively treat with surgery, craniospinal radiation, as well as chemotherapy. You want to aggressively treat this tumor. Next up is your craniopharyngiomas. So there's a couple of key features of craniopharyngiomas. You have your low-grade, it's a low-grade malignancy derived from remnants of the Rathke's pouch. They like to ask that. It causes compression of the optic chiasm, so you'll see bitemporal hemianopsia, as well as compression of the pituitary stalk, which can lead to types of endocrinopathies like growth hormone deficiency, as well as diabetes insipidus. And it's a suprasellar tumor, and it's a calcified mass seen on imaging. And remember that the bitemporal hemianopsia, that can cause the patient to run into the corners of the walls, into the furniture, because they can't see in their periphery. They can present with headaches secondary to compression of nearby structures, or they can get the headaches by an obstructive hydrocephalus. And finally, to finish this neurology peds, is Parinaud syndrome, and that results from pressure on the pretectal region of the midbrain. Findings are going to be a limitation of upward gaze with a downward gaze preference. What does that mean? Is that they're constantly going to be looking at the floor. They can't look up. They'll have bilateral eyelid retraction and light near dissociation. And the tumors that are associated with Parinaud syndrome are going to be your penial tumors. So guys, that will conclude neurology, the neurology section. So the first video again was internal medicine, and this video was more based on surgery, OBGYN, and pediatric neurology. So thanks again for taking the time to listen to the video, and I'll be doing another video pretty soon. So take care.